On to the next talk, which is now we are talking the cancer theme, and you can see different speakers are giving different perspectives. But now we have the real clinician, Dr. Aliasgar Moiyadi, neurosurgeon from Tata Memorial Hospital. He's going to talk to you, but before I invite him, let me give you a brief introduction about him.
Hello friends, welcome to yet another sneak peek into our biology and bioengineering summer camp. In this summer camp, we learn about the world of biology and bioengineering in the 21st century. Let us meet our guest speaker, Dr. Aliasgar Moiyadi, who will join us at the summer camp. Dr. Aliasgar Moiyadi is a neurosurgeon and professor at Department of Neurosurgery, Tata Memorial Hospital, ACTREC. He received his MBBS from St. G.S. Medical College and KEM Hospital, followed by an MS from Tata Memorial Hospital, Mumbai. He has super specialization in neurosurgery from National Institute of Mental Health and Neurosciences, Bangalore. He has established a neurosurgical oncology facility at Tata Memorial Center, which is one of its kind neurosurgical department in India. He has taken a keen interest in neuro-oncology, and his research focuses on understanding the biology of brain tumors, mainly gliomas, meningiomas, and medulloblastomas. He has been actively involved in multiple research projects with lab at IIT and ACTREC, and mentors many PhD students in their quest to understand brain tumors with translational utility. Dr. Aliasgar is a recipient of awards, fellowship, and travel cap, and is one of the very few surgeons in the country with very sharp research acumen. We are really excited to have with us Dr. Aliasgar. See you at the summer camp.
All right, so let's welcome Dr. Ali. And Dr. Ali, may I request you can share your screen and please give your presentation.
Yeah, hi, good afternoon, everyone. Good afternoon, Sanjeeva. Thank you. I'm just checking. Can you hear me?
Yes, Ali, everything is very clear and slide is in full screen mode.
Okay, fine. Great. Thank you. Thanks, Sanjeeva. And thank you for that very generous and kind introduction. So I must say that following on the theme of precision medicine, I'm going to deviate a little bit, change gears and go to precision surgery maybe. Of course, surgery is part of medicine. So since I can talk of what I do best, that's neurosurgery, I will talk a little bit about that. And rather than focus on any one particular aspect of the work, I'll just give you an overview of what we do and how science, technology, and medicine all come together to allow us to do what we do best. So at the outset, I must say, and I must ask all of you, and I hope that all of you are well and safe and healthy during these times. The last 1.5 years has been very uncertain. I'm sure many of you have faced challenges. And the way I look at it, challenges are actually opportunities in disguise. And once you have figured out a way of utilizing those opportunities, I think you can convert those challenges into something more meaningful and success even. And on that same theme, what I'm going to be talking in the next 15 to 20 minutes is the challenges that we face as clinicians, as surgeons, as doctors, and maybe everyone in whatever sphere of life, and how we work collectively towards overcoming those challenges and producing optimum outcomes out of those challenges. So this is the place where I work at, two beautiful campuses, one the Tata Memorial Hospital at Parel in the heart of the city of Bombay, and the other ACTREC, which I think Dr. Amit Dutt also mentioned in his preceding talk, a beautiful, again, campus set in the outskirts of Bombay on a huge campus. And I must acknowledge right at the outset that the work that I do in the hospital is not a one-man effort. It's actually predominantly a result of the beautiful, wonderful team that we have, clinical team, and of course, a very important research team, which I will mention in the later part of my talk. So to give you a brief overview as to what we do and as neurosurgeons, I predominantly treat brain tumors and, of course, tumors of the spinal cord. Brain tumors, or tumor in general, you're all aware, is an unwanted growth. And for some of you who may not be very familiar with these images, these are actually MRI scans of patients who had the brain tumor. And if you can appreciate this whitish patch, ring-like white enhancement over here in these scans, is the brain tumor. They come in different shapes and sizes and different pathological varieties also. Gliomas are the commonest that we deal with, and I will use gliomas as a representative tumor for the rest of my talk. There are many components of the treatment, and surgery is one of them. And I must say that without bias, though I'm a neurosurgeon, that surgery is one of the more important, or maybe the most important component of treatment of a lot of the brain tumors. However, it is easier said than done. If you can see this image over here, what I'm showing you is that there's a tumor in the center surrounded by brain. And if I have to go in and remove this tumor, I must be able to identify where the tumor is, not just on the MRI, but actually during surgery, as well as I have to figure out a way of trying to reach that and remove it completely at the same time, not disturbing or minimally disturbing the surrounding normal tissues, the brain, which is all around this tumor. To complicate matters, the brain is a very, very densely eloquent structure, we call it, functional structure. And if all of you have studied in biology the structure of the brain, there are different parts of the brain, different functions. And the tumor actually, unfortunately, can just occur anywhere in the brain, in any of these areas. The problem is that though the textbooks show you these beautiful annotated pictures and images of the brain, actually, in real life, the brain looks like this. And more so complicated during surgery, what we see is just a small part of the brain, because you don't open up the entire skull while operating on the brain. And therefore, whatever decision-making has to be done, or whatever has to be done, has to be based on this small window that you have. And therefore, the challenges, talking of challenges, as I said, the theme of my talk is going to be challenges. What is the challenges is that we work in narrow corridors. There are limited exposures. You have to look beyond what is just seen on the surface. And at the same time, you have to balance function preservation along with removal of tumor. And this is the balancing act that we have to play day in, day out, every minute, every hour of the surgery that we are in. In order to achieve that balance, the primary goal is to minimize errors, if not eliminate them. And this here is the Swiss cheese model of accident causation, whereby any act that you undertake, be it doing a surgery, be it crossing the road, be it manning an aeroplane, there is a possibility of an error always. And to avoid and minimize all those errors, there are multiple layers of defenses that we have put in place. And each of these layers is like this Swiss cheese slice, which has multiple holes. And the idea of having multiple layers of defenses is so that these holes don't align with each other, which means that at each point, there is a check for a mishap or a mistake that may have occurred at the other step, unless all these holes align together and you have a resultant error because of a particular action that you've taken. So the idea of this model or this concept is that you have in any field, any sphere of activity, you have, if you have to achieve excellence, you have to have multiple checks to ensure that you minimize errors and you achieve the accuracy or the endpoint that you're looking for. So we follow the same thing in medicine, and in neurosurgery, we do that by turning to technology. A microneurosurgery is what is the routine way in which surgery for the brain tumors is performed. We use state-of-the-art microscopes, surgical microscopes, to provide illumination and magnification. Again, this is where technology, optics heavily feeds into neurosurgery. You have high-powered electric tools, micro instruments. All of this make life very easy. However, there are still challenges in removing these tumors. And that is because of two problems, major problems. One of them being the limitations of human capabilities, both in terms of visualization. That is where you are not able to see the tumor the way it is seen on the MRI. Mind you that the MRI shows it very well, black and white, but it's never black or white in real life. So you have to be able to identify the tumor, and you've been able to remove it. And at the same time, you need a particular skill set, dexterity, which is testing sometimes human capabilities to the limit. So you again turn to help. And the way we do that is, again, use different kinds of technology, which we call as adjuncts, technological adjuncts, which help us to compensate and maximize the resection on the one hand. And I will talk briefly about these to give you an idea how that is done. So it's navigation, there is imaging, there is optical imaging and fluorescence. And at the same time, because we have to balance this with preservation of function, we do what is called as brain mapping. Again, a very exciting field, and I will give you a brief glimpse of that. All of this is tools that we use during surgery. It feeds in a lot of information, and therefore you have big data in research in biology and bioscience, but you have a lot of data also being generated in the surgery. And unfortunately, all this data needs to be assimilated within split seconds by the surgeon who is operating in order to achieve the best outcome. A brief glimpse of what these technologies do and how we use them. Navigation. Now, navigation is something which most neurosurgeons use routinely during surgery. And for most of you who have no prior knowledge of neurosurgery, navigation is nothing but the GPS system. And all of you have used a GPS system, be it in your mobile phones, in your cars. And what the GPS system does is nothing but it uses some kind of triangulation in order to give you a localization of your anatomy. And in case of neurosurgery, the anatomy is the MRIs, the maps that are fed into the navigation system. This is the system that we use. And what this system does is then it lets you visualize beyond the surface even before you've opened. And these are actually videos from the navigation screens that we use during surgery, which I'm showing you here. So you can see there's a tumor which is outlined in red, and there are different structures which we have marked, which depict certain functional areas in the brain which we want to preserve. And we plan and we rehearse the surgery even before starting it. So a wonderful help from technology which is used in real surgery. However, there is a problem with technology, and this is illustrated here. On the right-hand side, you can see there is a snapshot of maps. If you realize that the maps depend on whatever information has been fed into the system. Now, supposing some of the routes change and your map has not been updated, and you follow that GPS system, you will obviously be led along the wrong route. It may be a dead end, and worse still, it may lead to a disaster. The same thing happens during surgery in brain tumors. When you open the skull, the hard skull of the brain, which is where the brain is housed, there is a slight change in the structure of the brain, because the brain, all of you must understand, is not a solid hard object. It's a semi-solid soft structure which deforms, and that leads to a change in the anatomy of the brain compared to what the scans were acquired before you have opened the skull. And therefore your maps are now wrong. And if you follow them, you will lead to, you might land up in trouble. So how do we circumvent that? Again, technology and science helps us. We do updates of that imaging intraoperatively. We use complementary imaging techniques like ultrasound or intraoperative MRI, again, to update the system and the maps in real time on the go. And that's how we get better and updated information. At the same time, we need to account for automation, both of the technology and the system, as well as of human capabilities. And all of you are aware of robotics. I don't need to go into those details, but robotics is omnipresent. We see it in daily life. It's heavily used in industry and manufacturing. It's also used in your laboratories, and it's also used in clinical medicine and surgery. There are different kinds of robots that are there. Most of them are passive in that they assist the surgeon, hand-holding kind of robotics. Very few of them have complete autonomous solutions where the robotic device performs the entire procedure, of course, pre-programmed by the operator or the surgeon. It's done in certain fields of medicine and surgery, In neurosurgery, it still has not reached a stage of implementation. Primarily, the problem with autonomous is that it still today, robotic technology cannot fully account for and mimic the feedback, the sensory feedback that is important for making split-second decisions during surgery. For example, the visual feedback of change in color or blood coming from somewhere, or the change in texture because of pressure on some part of the brain, for example. The haptic tactile feedback is still not fully replicated by the robot. And this is an area of open research. And maybe, who knows, one of you some years later may have a solution for that. For our part, we have been collaborating with a brilliant team of scientists from the robotic department in the Baba Atomic Research Center in Bombay for devising an indigenous robotic system, both passive arm as well as the autonomous solution, along with all the required navigation software. And we have a wonderful team of scientists there who have made this possible, and we are in the phase of clinical validation of this completely indigenous solution. The techniques I talked about right now were the ones focusing on this part of maximizing resection. I will come to fluorescence a bit later, but right now, let me shift attention to function preservation and how we do that. And this is what we call as intraoperative brain mapping. Now, I told you that brain is a complex structure subserving various functions. We actually exploit knowledge from basic science, from neuroscience, where we know that the brain communicates, cells within the brain, neurons communicate by way of electrical signals. And therefore, we use controlled electrical pulses, stimulations, in order to investigate the brain surface to find out what functions are present in which part. For example, if you give a short electrical stimulation to a part of the brain which is controlling hand movement, there will be some electrical discharges in the hand which can be recorded, and you know that that part is functionally important. This is called as mapping, and this can be usually done with the patient asleep under anesthesia, which is normally what we do during surgeries. But for mapping certain complex brain functions like speech, cognition, understanding, mathematics, calculation, for example, you have to preserve all those functions. And during surgery, as I showed you, the surface of the brain, that nothing is written there that this is an important area and this is not. And often tumor and normal brain appear very similar. So how do we do that? We do that by doing awake surgery. And awake surgery is actually, I'm not sure whether you can hear this audio, but this is a patient who is being operated awake. You must have read of it sometimes. You must have seen it on some videos. But the patient is actually awake. And you'll be surprised to know that the patient has no pain because he's given local anesthesia. And then with the patient awake and doing certain tasks which are speech related, we stimulate parts of the brain and we find out if they are going to be involved in speech. And this is again an example where medical knowledge, cognitive neuroscience, and technology come together to provide you with an excellent state-of-the-art solution for doing some complex medical treatments. Moving on to another part of the challenges that we face. So far, what we've talked about is removing tumor or getting it out macroscopically, grossly. Of course, we use some surgical microscopes, but they essentially rely on your eyesight to understand, delineate the tumor, and we use all these techniques which are gross, macroscopic. However, all of us know that tumors spread at the microscopic level, at the cellular level. And often there is no way of picking that up. Yet again, you have science, technology coming to the help of the clinicians. And this is the concept of optical imaging in surgery. And this is an example in brain tumor surgery, but this is applied across in many different surgical specialties. One example of optical imaging is fluorescence-guided resections. And here, what we do is exploit the fluorescing property of certain naturally occurring substances within the brain, or for that matter, any part of the body. Fluorescence, for those of you who are not aware, is basically the property of certain substances, chemical substances within cells, to be able to absorb light of a particular wavelength, in our case here, blue wavelength, and then emit the light by modifying the wavelength to a different wavelength, and in our case, red. So when we use blue light to shine blue light on these tumors, when they are pre-treated by the dye called ALA, it emits a red light, and it's seen distinctly red from the surrounding brain, even at the microscopic level, and that helps us chase that tumor and remove it completely. Of course, combining functional mapping and other things at the same time. Again, here it's a knowledge of basic science, chemistry, and biochemistry, which helps us exploit this particular characteristic in brain tumor cells, glioma cells, where a particular enzyme, ferrochelatase, in the heme cycle. Now, heme cycle is a very important chemical cycle in the body, human body, which leads to the production of heme, which is a part of hemoglobin, this protein which carries oxygen in the blood, but also is important for many other things in the body. And what this does is that when you give aminolevulinic acid to the patient, it accumulates at protoporphyrin 9 because ferrochelatase is deficient, and protoporphyrin 9 fluoresces, and when it fluoresces, you are able to see it. And this is how we use the property of fluorescence in order to improve our resections, and this has become the standard of care in tumor surgeries for gliomas. Again, the idea of showing you this is to emphasize the need for crosstalk, for the need for having dialogue, and for having very solid and strong collaborations from the clinic and the basic science laboratory. This is what we mean by translational research. What we mean is research which is two-way. There is a clinical question, there is an answer provided by basic science, or there is a finding in basic science, which is then implemented in the clinic in order to produce a meaningful benefit. Of course, and you could have a wealth of information from the lab. And in the last decade or two, we've seen a huge explosion in the big data coming from the various omics, be they proteomics, genomics, metabolomics, because we've been collaborating with Dr. Sanjeeva for a long time. There is, and I think Dr. Amit alluded to it a little bit earlier in his talk, the need for having much more proficient and efficient bioinformatics tools to understand this data. And I'm sure machine learning and AI, which has already come into this field, will have a lot more say in the years to come. So at the beginning of my presentation, I talked about clinical collaboration, but I think very important for doing work which can be translated into novel therapies and novel treatments, to have a very strong collaboration with the basic science and the applied science laboratories. And I'm so glad to have support for the last many years, almost a decade, from Dr. Sanjeeva's lab and his brilliant students who've led to so many exciting things that we've done together. And just before I wind up, to give you an idea as to what something else that we came up with during this collaboration, and also to emphasize a very important point, which as a scientist, all of us need to understand and to actually cultivate, is to have a keen sense of observation, because often it's an act of observation or observation which leads to important clues, which can lead you further on to some novel discoveries. So I talked about fluorescence and how we use that routinely during surgeries. And when we use fluorescence, what we look for is red. The tumor which is red is going to be tumor which we want to remove. But however, it's not, again, an all or none phenomenon. And it is known and very well described that tumor parts, and tumor is heterogeneous, so the tumor parts which are extremely red and bright are supposed to be the aggressive parts, and the lighter or the fainter it becomes, the less aggressive the tumor is in those parts. You need to remove everything within functional boundaries, but this is the generally accepted heterogeneity. However, when we used it during our routine practice, what we observed was that we found areas of tumors which were aggressive biologically on pathology, yet they did not show the strong fluorescence that we expected them to. And this led us to go back and question established knowledge or established literature as to why this happens. Now remember, again, as young scientists, budding scientists, you should all also remember that science is a continuously evolving field, and nobody is right and nobody is always wrong. So therefore, it's always good to question existing knowledge, because unless you question it, you will not be able to improve on it. So we thought that we should investigate this more closely, and we did that exactly. And what we realized is that there exists another layer of heterogeneity within tumors. Besides the pathological or histological heterogeneity, there is a biochemical dissociation, a discordance between tumors within the same tumor. And this is something which has excited us. And this has been the topic of a collaboration with Dr. Sanjeeva's lab. And I must say that lucky to have Dr. Sai Charan, one brilliant PhD in Dr. Sanjeeva's lab, who's taken this upon as a PhD. There are many reasons why this can happen, this heterogeneity. We are in the process of exploring it. But what is exciting about this is that it has a potential to be modulated and manipulated in order to have a direct clinical and therapeutic implication. This brings me to my summary slide, which is that what I have recounted has been various actual experiences that we've had in the process of treating these tumors. It's not been a single one-man show. It's been a journey where I have been a character, and there have been many more characters and maybe more important characters. But like the F1 race, and a lot of you must be seeing Formula One, it's usually the driver who goes to the podium and is photographed. And I can say maybe the surgeon or the clinical lead will probably get that, take that credit. But unless your technical team, the guys who are managing your tires, who are making sure your pit stops are absolutely fine, you won't reach that podium. So it is important to understand and acknowledge that this is always teamwork, and the teamwork is mutual. There is nobody who's the senior, junior. There is always an equal distribution of respect and expertise. And it is with this kind of collaboration and teamwork only that we can actually improve. In our field, in my field, there is a scope of improvement. There are many things. I touched upon a few things, and these are all open to research. There's a potential to do a lot more. And I'm hoping that many of you in years to come will take up these challenges, and we'll see many more scientists, more engineers, and even maybe neurosurgeons from amongst those of you who are here in this camp. And if that happens, then I'll be the happiest person. With that, I'd like to say thank you. And I hope it hasn't been too much of a clinical or a boring talk. And if there are questions, I'm happy to take them or answer them on the chat.
Great. Thank you so much, Dr. Ali, for this wonderful lecture. No, it was a really interesting and inspiring lecture. I'm sure they all are mesmerized to see how well, a surgeon has to keep into consideration the technology, the biology, and the, everything has to come on the very, few millisecond to second time frame to take those decisions, which is very difficult to do during surgery. So students, you're all very excited. I can see you have a lot of interesting points in the chat. I'll just ask Dr. Ali one of your, question to just give some insight about the future of robotic surgery in India, how you foresee this field is coming up, and what will be your vision for that?
Right. Thank you, Sanjeeva. I think robotics is here to stay. It's already an established modality it's a standard of care for many different surgeries already. So not neurosurgery, but other fields of cancer surgery and general surgery, you already have the robotic system there. And I think it's only a matter of time before it finds its way into all different aspects. Now, there are two things which the robotic system does. It actually minimizes, or rather eliminates, a lot of human uncertainty in the execution of physical tasks, which is where you have things like dexterity and you have things like tremors, which humans can have, which is eliminated. And it also allows you to do multiple repetitive tasks without fatigue and with the same kind of accuracy. The problem that I see, and that's the challenge, is, as I already mentioned briefly, how this, because it's any procedure, any act that you do, and surgery is a complicated act, always is a complete reflex loop. So it's not just the execution, but it's also the feedback and the sensory information that you get, which allows you to tailor and modify each step of your surgery. And a robotic system, in order to get close to human efficiency and decision making in the split second for that, is quite a way away. So we have robotic solutions which are master slave, which are passive, But to have a completely autonomous active robotic system, I think we have a lot of way to go. And I must say that if they do come, they will replace surgeons. But I hope they are able to not replace, but at least augment surgical capabilities such that we are able to get the best outcomes.
No, thank you for this very elaborate answer. In fact, one of the participants, Kanak Sangvi, is saying that whether AI will replace the surgeons, right? So in the similar line, what you just explained.
I mean, I just like to reply once to saying that, artificial intelligence can't replace intelligence, but you have to have intelligence. I mean, I think we have to strive to make sure that AI becomes I, and that's something that we should look for.
Right. That's really wonderful. Thank you so much, Ali, for this wonderful lecture. And to all the participants, we can't take any more questions right now. I'm sure you're all also getting hungry. You are getting late for the lunch. So let me make, a few announcements.